acronym? You remember the?
On and on they shadow and down going like very interesting.
Awesome.
I had the first one right. I said smell, and I was right. So.
For which one?
And you said which was the first one? I said smell.
So what are the nerves themselves? What's cranial nerve 1? Olfactory. Optic. Skin the motor.
Trochlear.
Trochlear. Read them off computer screen. Trigeminal. Read it off computer screen. Abducens.
Facial.
Alright, so we got the trigeminal, yes? We got facial. Let's do the cochlear. We got balance done. Glossopharyngeal. Yes, no, part of it, some of it, all of it. So assisted swallowing is kind of a funky one because vagus is very much swallowing, so it's hard to use that as your test for glossopharyngeal. We can do parotid gland salivation, so I guess we go all Pavlov dog if I want to ring bells and see if you start drooling. An easier solution, though, is the cutaneous sensation on the external ear. So we've got the facial nerve that hits the majority of your face. What facial nerve does sensory on the face predominantly? Has a branch here, branch through here, branch through here. So let's differentiate. So which nerve gives us sensory to the face? Has 3 branches, which is a lovely clue to its name. Trigeminal. So what does facial do? Because it's very easy to kind of start making that twist. What does facial do that's different from sensory? Expression, right? Smile and frown. Taste on the front 2/3 of your tongue. Good. So separate those two just so you can acknowledge a little bit of that differentiation. But if you go back to trigeminal, then you'll see how the ophthalmic branch hits the frontal area over the forehead. The maxillary branch goes over the zygoma and the maxilla, and then the mandibular branch hits the mandible, and your ear is very much left open. So this is glossopharyngeal. So you can do sensory testing for glossopharyngeal by cutaneous, by sensory on the ear itself. And then to assess facial, we're going to do smile and frown for the motor components. And then we can add in taste for the sensory component on the front 2/3 of the tongue for facial. And then glossopharyngeal, you can do taste on the posterior 1/3, but sensory on the cutaneous of the external ear works easy as well. Vagus, cranial nerve 10. This does a lot. I mean, that's like half the organ systems in the body. No big deal. So, easiest assessment is swallowing. So have them dry swallow. Don't give them anything to swallow, just go swallow. You can watch them try to swallow, spit, whatever else. But recognize that, I mean, that's heart, that's lungs, that's liver, that's pancreas. Goodness, there's part of your stomach for the part of the gastric nerve. You're hitting with a splenic branch in there. Your kidneys, your small intestines, your large intestines. It kind of does a whole lot of stuff. Parasympathetic innervation, which means that we're looking at smooth muscle to all of these things. Peristalsis to help move these things down the line. If this freezes up, we have some issues. Bronchi and trachea, as well as cardiac muscle of the heart. It does a lot. Breaking it breaks you. Cranial nerve 11, spinal accessory. What does SCM stand for? If it's a motor, that means it's going to what kind of tissue? Sternocleidomastoid. It's going to a muscle. So SCM is muscle. So motor neuron, motor control is sternocleidomastoid and your traps. Easiest way to test this one is a shoulder shrug, which is going to be predominantly your trapezius. So you've got that occiput down through T12. It's grabbing, inserting into the spine of the scapula. So when you do a shoulder shrug, it's your traps lifting up on the spine of the scapula. You resist their shoulders, push down, and you're assessing the strength and the strength of the innervation, strength of the control of this motor nerve into those muscles. And then last one, hypoglossal. Motor to intrinsic and extrinsic muscles of the tongue. So, simple way, have them push their tongue on the side of their cheek, and then you push it into their cheek to kind of resist it. Yep. More difficult way, put on gloves, put your fingers on their tongue, and have them try to move like you resist their tongue motion. Olfactory, how do you test it? Close your eyes, smell this, what's it smell like? Easy way to kind of hang on to that if you've got a medical kit, honestly, is, well, ammonia works great. Or you have a smelling marker for kids. What's it smell like? Cherry. Awesome. Yay, it's a marker. Cranial nerve 2, what is it? What's the name of it? Optic. How do you test it? Follow or reading things, right? So we're looking at visual acuity and focus. And so that's your Snellen chart at the doctor's office. So read something at a distance to make sure they can have that clarity. And seeing as how the innervation for each eye is separate, you should have them do that with individual eyes. Three, 4, and 6 get lumped together frequently. What are cranial nerves 3, 4, and 6? Trochlear and abducens. What do? So like the oculomotor, they're motor nerves. It's motor control of eye movement. So oculomotor does which directions? Up, down, and medial. Superior, inferior, medial. Trochlear does what?
Down and out.
Down and out. And abducens does abduction, away. Right? Away from, so abducted, abducens. Good. So what did we just get? We just did 3, 4, and 6. What's number 5? Trigeminal. We have 3 branches. Ophthalmic, which goes over the eye. We have maxillary, which goes zygoma and maxilla, and then we have mandibular branch, which hits the jaw. All sensory. So you can take a Q-tip gently and touch. Does it feel the same on both sides? Can you feel that I'm doing this? 7. Cranial nerve 7. What is that?
Facial.
Facial. What are we doing with that?
Smile and frown.
Smile and frown, so facial expression. What's the sensory component?
Taste.
Taste. On the anterior 2/3 of the tongue, so just put something sweet on their tongue, put something sour on their tongue, whatever you want to do. 8, what's the name of it? Vestibulocochlear. So there's actually 2 branches. There's the vestibular portion and the cochlear portion. Which is hearing?
Cochlear.
The cochlear, like cochlear implants, when you hear about people who are deaf having that neural implant put in. So you can do auditory on left or right. So close your eyes and put up your hand on the side that is the side you hear something on. Again, those are separate innervations, so check them individually. Vestibular part, how do we assess it? Balance. Single leg stance. Cranial nerve 9. Glossopharyngeal, how do we assess it?
External ear.
There we go. External ear. It also does a lot of salivary glands, parotid. It assists with swallowing, so it's kind of assisting a few other things. But the easiest way to uniquely identify it is external ear. Number 10, vagus. Swallow, dry swallow is the easiest way to go about it, but it does smooth muscle contraction to a lot of stuff through the thoracic cavity. Parasympathetic slows down the heart, parasympathetic innervation to the lungs. Then 11, spinal accessory, which goes to what? How do we test it? Shrug your shoulders, goes to sternocleidomastoid, and it goes to your traps. And that leaves us number 12. Hypoglossal, which does what? Moves the tongue. So we can resist it with tongue movement. Yes, ma'am.
How do we test glossopharyngeal?
So that's the one that's cutaneous to the ear. So there's a lot of stuff it does. Assists with swallowing, but it's not, it assists with a lot of stuff.
But there's no specific.
But the most specific is that we can assess cutaneous to the ear. It also does the posterior third of the tongue for taste, so you could go that route. But differentiating that from facial for the anterior 2/3 might get tricky. So easiest is the cutaneous to the ear. Okay. Okay. Mastication ventilation. Last two pieces and we're done with this section. Then we get on to fun stuff with shoulder. Yay, shoulder. So much excitement. You guys are ready for Christmas already? No? Yeah? Yeah. You're tired of making it. It's cool. Alright. Mastication. So the jaw, we're going to talk about movements of the face. We don't have a whole lot of new muscles to focus on. There's not a whole lot of new motions that we're looking at. But I do want to introduce you to the kind of the form and structure of the temporomandibular joint, the TMJ. So you kind of understand a little bit what that popping, clicking, and certainly that locking can be. So the joint structure. In here, we've got two principal muscles that we're adding in. We have the lateral pterygoid and the medial pterygoid. The lateral uniquely is the superior head is actually directly connected to an articular disc. So we have a direct muscular control for this disc. You guys ever watch a snake come up and eat something? On a good documentary film, it actually dislocates its jaw to get around whatever it's eating. Well, people do that just a little bit as well. So when we open our jaw wide, this head of the mandible actually shifts down and out. It separates out of that fossa up in here. And that articular disc gets pulled by that muscle to shift it in unison to help keep that thing moving, which I think is pretty cool. And you can feel a lot of that motion. So if you put your finger, there's your ear holes, right? The external auditory meatus, and you come just in front of it, you can feel it shift. Now, if you're going to assess somebody for a dislocated jaw, put your gloves on, and slide your finger in their ear, and you can feel that articulation through the ear. Far more clearly than if you get the external side. So again, that just kind of makes it very unique that we've got this articular disc that's actively being moved by a muscle to help assist with that somewhat dislocation and then rearticulation as it slides back in and out. So the principal muscles we have, you've got the masseter, the temporalis, and then you have the medial and lateral pterygoid muscle. So masseter is the most superficial. It's on the outside, helps pull the jaw, elevate the jaw to where we close that bite. The temporalis comes from above, under the zygomatic arch, and helps as well elevate that jaw. So, actions that we principally want to worry about: elevation, closing the mouth, masseter, temporalis, and the medial pterygoid. Where's medial pterygoid? It's right up in here underneath the masseter. So is it direct, like north-south orientation, superior, inferior? So you can kind of see how when that contracts, it pulls it up. Now the superior head of the lateral pterygoid, which we talked about moments ago, stabilizes and adjusts the position of the articular disc. So that little piece, that little band of a fiber, is going to help tug that articular disc to help it keep in line with the head of that mandible. And that's like the coolest sleeping bag ever. Depression. Depression of the jaw means we're depressing, we're dropping it down, we're opening it up. So suprahyoid muscle is up in the neck underneath. The lateral pterygoid is the other one that helps pull it down. That's not a lot of muscle. These are really small. We don't have nearly the strength to open our mouth as we do to close it, which would be very surprising because some people seem quite incapable of closing their mouth. Terribly funny. Which is terrible, I'm not quite sure. So, the reason I put a croc up there, so if you guys ever watch like guys wrestle crocs, they're the same way. They have tremendous strength and ability and power to close the mouth, but they're very, very weak at being able to open it. So you can actually grab a croc's mouth. I don't really recommend going and trying this too often, but if necessary, grab it closed before it decides to open it, and it closes it for you. So, because their strength and opening is very, very far removed from their ability to close it themselves. And I like that picture because it's pure cannibalism. It's a croc eating a croc. It's tragic. And Haley's like, yeah, you told that joke yesterday. So last week. All right, so lateral excursion, moving it side to side. Medial pterygoid, lateral pterygoid, both heads in the lateral. Being able to grab that jaw and shift it from side to side. It's unilateral contraction of those muscles to pull it to one side. And then we're going to do protrusion and retraction. So shifting the jaw like your underbite, shifting it forward, and then retraction, pulling it back. So protrusion, the masseter and both pterygoids. Stick it forward. And retraction is your temporalis, pulling it back. And you can actually feel that. So take your fingers and put it over your temporalis muscle, over your ear. Stick your jaw forward, and when you pull it back, you can feel the contraction right above your ear. You can feel that muscle, that nice banding of the muscle kind of going with it. So, Tmj dysfunction. Anybody's jaw pop, click, or mom and dad or somebody pops and clicks. So that's a lot of what we're looking at is trying to identify what's going on with it. That articular disc that slides in that space, as that mandible moves, shifts forward, as that head of the mandible shifts anteriorly, as we fully open that jaw, that superior head of that lateral pterygoid yanks, pulls, guides that articular disc to go with it. So we have a neuromuscular control of that disc to help maintain that muscle, to help maintain that jaw in the right place. So abnormal TMJ, anterior displaced disc, to where it's not shifting, and its distal end is pulled out and stretched to where that shifts back and kind of pinches without having the particular disc in place. or even worse, as the disc atrophies and changes shapes, and this tissue degenerates, then we start getting things locked up. And so, normal clicking versus locking. Clicking is that disc kind of slipping in and out of place. So for people who have that, I encourage you not to constantly do it. For people tend to go, if they have an injury, they're like, it hurts when I do this, it hurts when I do this, it hurts when I, well, don't do that. If you keep clicking it, again, you're kind of grinding that thing in place. And so, again, you want to kind of get that managed and treated before you get that worked on. There's some PTs that do some wonderful work with it. And then locking, to where it's stuck behind, where it's getting pinned up on that retro, the tissues that go in behind it. And it stays off of that articulate disc, so it's not benefiting that joint to where it's stuck and not able to resolve. And there are folks who definitely work with this far, far more than I do. But I thought it'd be appropriate for you guys to kind of know the basic anatomy of what's going on. And that brings us to ventilation. Breathing, yay. Everybody's favorite graph. Favorite chart, yeah. Carl's crazy. He's going back to slides.
I was on the test last time.
It was on the test last year. You know,
Scared me.
This year too.
Mm-hmm.
Scared me.
So as you sit there, so this is nothing more than vocabulary. You understand the basic of the vocab, and in the processes start making sense. That's the theory anyways. Tremors might prove otherwise. First place to focus is tidal volume. Right up through here. It's just your basic in and out. Sitting here, resting, watching the lecture, watching class, your normal in, your normal out. That's tidal volume. If I ask you, after you take in your normal breath, to breathe in more, you can. Because you have this inspiratory reserve volume. There is more that your lungs can take. You don't need it now, so you don't take it now. But if I asked you to, if you had to blow up a balloon, you could pull in more. And you can pull in voluntarily up to your maximum. You add those two together, your tidal volume with your inspiratory reserve volume, and that's your inspiratory capacity. As much as you can breathe in. Okay, on the flip side, you breathe in, you breathe out. And as you breathe out, if I ask you to completely exhale, to completely push everything out that you can, that extra bit, looks like that was your inspiratory reserve, this is your expiratory reserve. But recognize that that doesn't get you to bottom out all of your volume. So you can't voluntarily push out everything that's in your system. Having a little bit in there helps maintain a little bit of positive pressure to where the alveolar sacs stay open, all that kind of good happy stuff. So that residual volume. When you have an athlete on the field who suddenly gets hit in the gut and that forces out some of that reserve, that residual volume, and all of a sudden they have to stop because they got to catch their breath. They got to jumpstart that system again. Knocking into that residual volume, it just makes you break into song. Take my breath away. So that is beyond your tidal volume, that's your functional residual capacity. That's the leftover that you have beyond your tidal volume, your normal in and out. This vital capacity is everything, your max inhale plus your max volitional exhale, leaving that residual volume. And then you add that residual volume back in, and you get total lung capacity. Clear as mud? Cool. And now for the muscles. Inspiration. Our goal is to take our thoracic cage and increase the internal volume by stretching it out. So that's done in a couple ways. Your scalenes, we'll start there. Where are your scalenes? Where do they originate? Where are they? How did we find them? What was that process that we went through? In there. They're here, transverse processes. So if you want to find them, that trail that we go, you find your upper traps, right? So we're going to go the distal insertion of the trapezius is spinous scapula. You elevate your shoulders, you can grab the upper traps. So you can feel that banding as it comes up into the occiput. So the origin, occiput to T12, insertion, spine of the scapula. But you can find it just by elevating shoulders. So that gives you that central banding that goes right up the middle, right across and over the laminar groove. Remember, if we go a little bit lateral, we get that muscle that goes diagonally up into the superior nuchal line. So what muscle do we feel in that little pocket right there? Splenius capitis goes diagonally from that lower cervical region, that the upper thoracic, C6, T2 in that range, diagonally up into the superior nuchal line. So upper traps, splenius capitis, and if I come just a little bit forward, I'm pushing in underneath my ear onto that mastoid process. What's originating on that mastoid process? SCM, sternocleidomastoid. So mastoid process, and what's the insertion point? Where does it go? The sternocleido part. So sternum and cleido means what bone is cleido? Clavicle. Because we discussed how if we have a fractured clavicle, people actively shorten SCM to where they put their head down and away from that fracture site. Because that muscle yanks on that bone and we don't want that pressure there. Okay, so finding SCM matters. If we go anterior, that little pocket, then we find carotid artery. But if we go posterior, just behind it, then coming off, you're pushed on transverse processes if you push directly in. And coming off of those transverse processes, those are our scalenes. So your scalenes are going from transverse processes, C2 to C6, straight down into your first and second ribs. So why do I go through all of that? Okay, so they're elevating, they're pulling up on the first and second rib, which elevates that thoracic cage, which helps open it up. So scalenes are first one. Intercostals we haven't talked about before, but in between each of your ribs, you've got internal, external intercostals. The externals are going to help pull the outsides of the ribs, kind of roll them out a little bit to help expand that thoracic cage. And then we cap that off inferiorly with that diaphragm, which runs across, and when it contracts, it draws down. It pulls all of that up. So we spread all of this up, and then we draw it down with like a plunger. And so that increases this space, which increases negative pressure. So doing that draws in air to help fill it with the lungs. Now, if we want to do forced inhalation, we want to breathe in really hard. There's a lot of other muscles that are anchored on the ribs that act on the rest of the body. Pec major, the things that we get, pec major, pec minor, coming off of sternum and off of the upper ribs that make the arm move. We can do sternocleidomastoid, we can do levator costae, we can do serratus posterior, anything that's, bless you, that's originating on the ribs that are supposed to act elsewhere. We can turn that around to where all of a sudden elsewhere becomes the anchor point and everything pulls on the ribs to quickly pull them apart, elevate, expand. So that forced inhalation is everything that's attached to the ribs, drawing that apart as quickly as possible to create that space as quickly as possible. Quadratus lumborum grabs on that 12th rib from the ilium. Usually that's its anchor point. It lifts the pelvis, but it can act on from the pelvis onto the ribs to pull it down. Forced expiration. So I want to blow out really hard. Abdominal muscles in through here. Internal, external oblique, transverse abdominis, internal intercostals, so the insides, the muscles on the inside of those ribs, again, try to help collapse and pull down. And all of that pulls in, collapses in. Transverse abdominis comes across, everything draws inward to collapse that lung space to push it out hard. When you're trying to blow up that balloon, and your face turns beet red, you feel like the vein's going to pop. So why do I not have a relaxed expiration? When I have a forced inspiration, I have a forced expiration. I have the muscles that give me relaxed inspiration. Why do I not have muscles that give me a relaxed expiration? That tidal volume, when you're sitting here and you breathe in gently and you breathe out gently, what is driving that exhalation in a relaxed tidal volume sense? Why is it not up here? Because we just don't care. Why? Alish. Do I have muscles acting on my lungs? Nothing attaches to my lungs. What are my muscles acting on? The ribs. They expand that rib cage. The diaphragm pulls like a plunger to kind of open that system up, creates a negative pressure. So what creates relaxed expiration?
The pressure difference?
Yeah, the pressure difference. I mean, we're creating a negative pressure, and as soon as we take and relax those muscles, it all recoils back to its normal shape, and that recoil is gently breathing that out. So it's like taking a rubber band. I take muscles to tighten it, but as soon as I relax, then it goes and it recoils back. It doesn't take extra work to do that. I've already put the potential energy into it. When I release, it does the kinetic energy on the other side to push it back out. So drawing in air is easy. Well, drawing in air is the work. Pushing out air is the easy part. That's it. So, not much for new stuff. Mastication ventilation. And the next class we can go through and refresh on the muscles, ligaments, femoral triangle, all that good stuff for the head. Our test will be next week. Easy enough? Stressful enough? And then from there we will go from the sternum in the sternoclavicular joint and work our way down and out through the upper extremity. We will add back in the nervous system. We will talk about the pathway of the principal arterial system, and that's this class. So I would take some time to kind of refresh notes, refresh some ideas before next class, because that way you know what questions you have before Sunday night. All right? So you can come in ready to ask a few, to bug me about a few, to make sure that you've got clarification on what you need.